Good afternoon. This is our second presentation on the urinary tract renal system. This one is related to alterations of renal and urinary tract function. Okay, we begin with urinary tract obstruction, and this is when there's a blockage. The obstruction can be caused by an anatomic or functional defect, obstructive uropathy. The severity of this obstruction is based on the location, the completeness, involvement of ureters and kidneys, the duration, and the cause. Upper urinary tract obstruction includes a hydroureter, or the accumulation of urine in the ureter. If you have urine in the ureter, it's predisposed to develop bacteria. Hydronephrosis, an enlargement of the renal pelvis and calces. Uterohydronephrosis is a dilation of both the ureter and the pelvic calceal system. And this is what happens when you have a urinary tract obstruction. So you can see there's an obstruction. See how this is, the ureter is narrow, and it's causing hydronephrosis of the kidney. This is a polycystic kidney, and it makes it so that this kidney is virtually doesn't function. So sometimes these kidneys just die. Sometimes they can go in and fix whatever's broken, and then it will begin to work properly. Here's some other, you can see there's a uteropelvic stricture here where it's narrow, a fibrous band, stenosis. So sometimes they can go in and fix these things, and unfortunately sometimes they can't. So different types of strictures that cause urinary obstruction. All right, upper urinary tract obstruction, compensatory hypertrophy and hyperfunction. So you're going to see that the kidney gets larger. Post-obstructive diuresis will cause nephrogenic diabetes insipidus. Another very common one are kidney stones, and kidney stones are incredibly painful. Some risk factors here related to gender, race, seasonal, fluid intake, diet, occupation. They have found that people who drink a lot of soda are predisposed to kidney stones. And the kidney stones are classified according to the minerals that actually make up the stone. It's a supersaturation of one or more salts, and the presence of a salt is in a higher concentration in the volume, it can be dissolved. The growth into a stone via crystallization or aggregation. I'm sure some of you have seen kidney stones and what they look like. They can look like crystals actually, or they can look like a rock. Other factors affecting the stone formation: crystal growth inhibiting substances, particle retention, and issues with the matrix. Stones, the different types of stones that there are. Uric acid stones, you'll see those in people with gout, struvite stones, calcium oxalate or calcium phosphate. Some people have elevated calcium levels in their body, and it causes an increased risk of stones too. The manifestation of kidney stones is renal colic, and it's incredibly painful. I bet at all of our emergency room nurses can pick one out when it walks through the door. Excruciating pain, often fall to the floor, can't get up. Vomiting is common due to the pain. Imaging studies and a 24-hour urinalysis. The treatment, we're pushing fluids, decrease in dietary intake of the stone-forming substances, and then the stone removal. So stone can be removed in a couple of different ways. If it's low enough in the ureter, because actually what happens is that stone drops from the kidney and goes into the ureter. And imagine it's a stone, it's got sharp edges. Those sharp edges are causing incredible pain as it's going down the ureter. If it stops and stops moving, that pain will subside. Or if it drops into the bladder, the pain goes away. It's very interesting to see it go. Now, sometimes if that stone is low enough in the ureter, the urologist can go in with a scope through the urethra and actually grab it and pull it out. Um, they'll often put a stent in the ureter to enlarge the circumference of it a little bit to ease the passage of it. In some cases, when they're unable to retrieve it, they need to do lithotripsy, where they actually break the stone up using ultrasonic um, waves, and then it is urinated. Okay, sorry about that. I pushed the button too fast. But neurogenic bladder, dyssynergia. We have when the detrusor muscle is hyperreflexed, it's overactive. When it's areflexia, it's underactive. Overactive bladder syndrome is increased frequency and urgency, often nighttime urinating. There's some medications that we use to try and help with that. Obstruction, urethral stricture, prostate enlargement, pelvic organ prolapse, partial obstruction of the bladder outlet or the urethra. All of those things can contribute to neurogenic bladder. Tumors. There are renal tumors, bladder tumors, adenomas, renal cell carcinomas. The transitional cell carcinoma is most common, and the most common symptom of a bladder tumor is painless blood in the urine. It's more common in men greater than 60 who smoke. So anytime that there is blood in the urine that can't be accounted for, it needs to be investigated because it's never normal. Unless there's been some type of a trauma that would cause it, it shouldn't be there. Urinary tract infection is a very common occurrence. It's caused by an inflammation of the urinary epithelium by bacteria. Acute cystitis is the same thing as a urinary tract infection or a bladder infection. We usually break the words apart. It's an inflammation of the bladder. Painful bladder syndrome or interstitial cystitis is quite common also. With interstitial cystitis, women come in complaining of symptoms of a urinary tract infection. However, they don't have one. Interstitial cystitis is a chronic inflammation of the bladder wall. And this chronic inflammation causes little cracks in the bladder, which are incredibly painful. These patients need to be followed through. It's in women, and I always refer them to a urogynecologist. Urogynecologists are physicians that practice urogynecology only on women. Um, Urologists are wonderful physicians, but their main focus is on men with prostates and things like that. So I would prefer females to go to a urogynecologist. It's a more specialized field. And then we have acute and chronic pyelonephritis. Those are the kidney infections. Those are the really dangerous ones. Anybody presents with symptoms of a kidney infection, they're going to the emergency room because they can go into sepsis quickly. The most common bacteria associated with urinary tract infections is E. coli. And E. coli, we are only going to know this by sending a culture and sensitivity off to get checked. The virulence of the uropathogens, host defense mechanisms. So these bacteria proliferate, and normally what happens is we get a little bacteria in our bladder, we urinate it out. In cases of urinary tract infection, those colonies have built to the level where we can no longer rid them, and they begin to pose a problem. Now, the interesting thing with E. coli, we talk about cranberry juice and urinary tract infections. E. coli is the only bacteria that will be receptive to cranberry juice, and the reason for that is cranberry juice does not allow E. coli to adhere to the bladder wall. So it may not be curative, but it can certainly help reduce those colonies, and if the colonies are reduced, you're going to have fewer symptoms. The symptoms associated: frequency, painful urination, urgency, sometimes lower abdominal or suprapubic pain. We may have low back pain also. Anytime we have low back pain, I begin to get concerned that this infection is going up to the kidneys. The treatment is antimicrobial therapy. fluids, avoidance of bladder irritants, and urinary analgesics like azo or pyridium. Those are antiseptics that help reduce urinary spasms. Um, we don't want any bubble baths, nothing that's going to irritate the bladder, like caffeine is a big irritant. Lots and lots of fluids. Antibiotics are chosen by the bacteria. Now, if we've done a urine dip, we aren't going to know what the bacteria is. So, my first line drug of choice for those under the age of 60 that present with a urinary tract infection is macrobid. Macrobid does not perfuse to the kidney, though. So if they are presenting with back pain, you will never use macrobid. You're going to use Cipro or Bactrim. Anybody over the age of Cipro, anybody over the age of 60 cannot use macrobid, so you're going to use Cipro or Bactrim. Those are the most common drugs. We talked about this a little bit, that painful bladder syndrome or interstitial cystitis. There's no single treatment that's effective. We work on helping with symptom relief. Kidney infections can be quite dangerous, and these patients are going to go to the emergency room because often they need a dose of IV antibiotics to get it under control. Glomerular disorders, we have glomerular nephritis, which is an inflammation of the glomerulus. Immunologic abnormalities is the most common, but it can also be caused by drugs, vascular disorders, secondary systemic disease, or virus. We have the mechanism is a deposition of circulating soluble antigen antibody complexes, often with complement fragments. Antibodies react in situ against the planted antigens with glomerulus type 2 hypersensitivity, cytotoxic. Also, non-immune can be related to drugs, toxins, and ischemia. So we know that there are certain substances that are toxic to the kidney. So we would like to, especially if someone who has a reduced glomerular function, we have to be very cautious about the medications that we are prescribing that are go through the kidney. Two major symptoms. We have blood in the urine and protein in the urine exceeding 3 to 5 grams per day. Oliguria, hypertension, edema, nephrotic sediment, and nephritic sediment. There are different types: membranous nephropathy, glomerular nephritis, and a rapidly progressing glomerular nephritis, and then we have a chronic. They excrete more than 3.5 grams of protein in the urine per day. So this is a patient we need to have a 24-hour urine on so that we can see how much protein they're excreting. The protein excretion is caused by glomerular injury, and your findings will show that there's hypoalbuminemia. So we've got, what does that mean? Low albumin in the blood, edema, hyperlipidemia, and lipiduria, high lipids in the blood, and vitamin D deficiency. Those are findings we're going to see. And these are different types of nephrotic syndromes. Acute kidney injury, renal insufficiency, renal failure, and end-stage renal failure. Prerenal is the most common cause, and this is related to an impaired renal blood flow. I actually have a friend who has a stricture of the renal arteries, and she had to have stents put in the renal arteries. So instead of having stents in the coronary system, she needed stents in the renal arteries because that was causing her to have elevated blood pressure, and also it was causing damage to the kidneys. Intrarenal. Acute tubular necrosis is the most common cause of intrarenal failure, and postrenal occurs when with urinary tract obstructions that affect the kidneys bilaterally. So if they are affecting the kidneys bilaterally, both kidneys are affected. So when it's unilateral, the one kidney is able to compensate for that. So when they're both affected, it can't work that way. There are different phases. The initiation phase, where the kidney injury is evolving. At this stage, prevention of injury is possible. The unfortunate thing, though, is cases are very rarely caught at this stage. Maintenance phase, we've got an established kidney injury with dysfunction. Urine output is lowest during this phase, and serum creatinine and blood urea nitrogen both increase. The recovery phase, the injury is repaired and normal renal function is reestablished. Diuresis is often common at this stage. A decline in serum creatinine and urea, and why is that? Because now the body is able to get rid of the creatinine, so you're going to see it decrease in the serum, and it's going to be increased in the urine. Chronic kidney disease is progressive loss of renal function that affects nearly all organ systems. We see this in patients with hypertension, diabetes, and intrinsic kidney disease. And these are the different stages of it, and it is staged by the glomerular filtration rate. And this algorithm illustrates chronic kidney disease. Proteinuria and uremia is due to the glomerular hyperfiltration. It damages that interstitial tissue. The creatinine and urea clearance is going to cause the glomerular filtration rate to fall and plasma creatinine increase. So anytime that creatinine is decreased in the urine, it's not just disappearing, it's increasing in the blood. Fluid and electrolyte balance. So remember, salt loves water. So sodium excretion increases with obligatory water excretion, leading to sodium deficit and volume loss. Concentration and dilution ability diminishes. Potassium balance is all messed up because potassium and sodium are dependent on each other. So tubular secretion increases early. Once oliguria sets in, the potassium is now going to be retained. Acid-base balances will be off now because metabolic acidosis will set in when the glomerular filtration rate is 30 to 40%. All right. Fluid and electrolyte balance is affected. Calcium, phosphate, and bone. We have reduced renal phosphate excretion, decreased renal synthesis, vitamin D, and hypocalcemia. These patients were at increased risk of fracture. Protein and carbohydrate and fat metabolism are all related to chronic kidney disease. Anemia will result in lethargy, dizziness, and low hematocrit, common due to the interference with erythropoietin. Alterations seen in the following systems. So all these systems are affected by chronic kidney disease. These are some of the signs and symptoms of kidney failure. I think most common, you're going to see that itching, that crazy itching, and bruising is very common also. Edema. So all of these symptoms are associated with kidney failure.